Hi, everybody, and welcome to another CCF live event here from beautiful Cleveland, Ohio. I want to just start out by pointing that you'll see the sun is in my eyes. I had to change my camera because it's so incredible here in Cleveland. And we're absolutely pleased that all of you could join us. Super excited to have our panel tonight, and we want this to be an interactive session. I want to remind everybody that the chat box is something that we're going to be monitoring. And again, reach out. All of our panelists are going to be monitoring that. We'll try to get to the question and answer system. We're starting out with a little bit of some good talks. But again, it's a wonderful opportunity. If we can't get together in person, that we could come together and go from there. So just as a little bit on behalf of my co-moderator, Dr. Michael Valente, who leads our stage 4 colorectal cancer program, we have 700 healthcare providers over that from over 65 countries. I love this map that Rita puts together, just showing how the globe has shrunk and how we can all come together. So I want to introduce today's panelists. Next slide. I should say first, thank you so much for these wonderful companies, Ferring Pharmaceuticals, Medtronic, Bristol Myers Squibb, Janssen Scientific Affairs, and Olympus for really providing us the educational grants that we could come together and having partial support for this activity. And so thank you very much to our sponsors. Next slide. So I'd just like to introduce our panel of what we have of our experts. And again, I encourage everybody to reach out on the chat box. So I'm Scott Steele. I'm the chair of colorectal surgery here at Cleveland Clinic. I'm going to turn it over shortly to Dr. Michael Valente, who is our program director for our fellowship. For all you trainees out there who want to be colorectal surgeons, he's the guy that you need to talk to. And Mike leads our stage 4 colorectal cancer program here and also does our HIPEC and Cytoreductive Surgery, which we'll be talking about a little bit later. Dr. Federico Osiero, who is our director of our liver cancer program. When I get into trouble, he's one of the people that I call and goes from there. Dr. Asan Balamagwala. Asan, I did that one right, I think, tonight. I got it down there. So Asan is one of our radiation oncologists, GI expert, does a lot of our intraoperative radiation therapy in our SBRT, and we work hand in hand on a lot of novel programs. And Dr. Aaron Berger, who leads our liver ablation, our tumor ablation ones, also very heavily involved in the things that we do. Next slide. In addition, we have Sumil Kamath, who is one of our GI oncologists here at the Cleveland Clinic, and Smitha Krishnamurthy, who is also one of our GI oncologists, very involved in a lot of the national programs with that. Cristiano Quintini, if you've seen any of the other programs, Cristiano, I include him on a lot of the things that we do. Cristiano is obviously one of our liver transplant surgeons and is highly involved in a lot of the hepatic resections from the metastases. And Dan Raymond, who is one of our thoracic surgeons, lead in thoracic surgery, who also does a lot with colorectal cancer metastectomies, as a part of our cancer executive committee for CCF, as well as the quality director for thoracic surgery. So we're extremely pleased to have this great panel, and again, having interactive sections. So with that, I'm going to turn it over to Mike Valente as we get started off the evening. So thank you very much.
Thank you, Scott. Thanks for the introduction, and thanks for all the panelists who are able to be with us today. We've compiled a group of I consider experts in the field. You know, stage 4 cancer affects a lot of different people in a lot of different ways. Not all stage 4 patients are made the same, and we have that mentality here at the clinic where, you know, every patient's a little bit different. And today what I wanted to do was give a little bit of different approaches just from the medical oncology standpoint, the radiation oncology standpoint, and then some cytoreductive surgery, peritoneal disease, liver, and then some lung. So obviously there's a lot of different things with stage 4, a lot of new things, especially medical oncology in the developments and clinical trials, immune therapy. We'll talk about those. Some groundbreaking stuff with radiation and liver disease as well. So really want to thank everyone for joining in from around the world. I'm looking forward to some good discussion. And as Dr. Steele said, please chime in at any time. This is an interactive event, and looking forward to getting a lot of comments and feedback and a good discussion today. So back to you, Scott, and I think we'll start off soon here.
Fantastic. And so if we can call up the slides and allow me to introduce Dr. Smitha Krishnamurthy, she's going to give us a little bit of some background in terms of what's systemic therapy for patients who present with, as we all know, upwards of 25% or more patients present with metastatic disease. So Smitha, turning it over to you.
Thank you, Scott. Thank you, Mike. I'm delighted to be here. We've got a lot to cover in 10 minutes talking about systemic therapy. These are my disclosures. As Mike was just saying, we do recognize that patients with colorectal cancer do not all have one disease. We're learning more about the biology of this disease and recognizing differences between right and left-sided colorectal cancer. You can see here, these are the most some of the most important molecular mutations in colorectal cancer, and right-sided tumors are more likely to harbor BRAF mutations or microsatellite instability, whereas on the left side, we're more likely to run into KRAS mutations and HER2 amplification, which is pretty rare in colorectal cancer, but 6% of RAS wild-type patients. So when we're thinking about systemic therapy for somebody with metastatic colorectal cancer, especially for initial treatment, there are a lot of factors to consider. And so we're all doing this, all of you are doing this at tumor boards. We're always wanting to know, is the patient potentially curable? Can this patient have resection with curative intent or surgery to at least help them live longer? They may have multiple sites of disease. Which site is most symptomatic? We may need to direct therapy there to begin with. We now know we need to know the microsatellite instability status to know if they can benefit from upfront immunotherapy, which we'll get into. When considering chemotherapy, most patients are getting doublets like FOLFOX and FOLFIRI, but we do know that the triplet regimen, FOLFOX-SIRI, does improve survival. So we have to consider that for our patients who are fit enough. And some patients can only tolerate single agent. We also need to consider, can we use anti-EGFR antibodies for improved response rate and survival? So there we look at right-sided versus left-sided primary tumor and the RAS mutation status. And BRAF V600E is very important to recognize because of its prognostic implications, and we'll look at there's a therapeutic implication. Bevacizumab is our only other antibody class we can use upfront, and we have to look at the risk factors for complications like heart attack and stroke with underlying hypertension and age when deciding who to use this for. And then, of course, we advocate tumor genotyping for all of our patients to look for other important alterations such as HER2 amplifications and NTRK fusions and other targets that could lead to participation in clinical trials. So we're going to look at the Keynote 177 trial that established pembrolizumab as optimal initial therapy for patients with metastatic colorectal cancer that's MSI high or has deficient mismatch repair. In this study, patients were randomly assigned to upfront pembrolizumab versus investigator choice chemotherapy. Progression-free survival was improved with pembrolizumab in the green line versus chemotherapy, with a median of 16.5 months with the immunotherapy versus 8.2 months with chemotherapy. Response rates were increased with pembrolizumab, the anti-PD-1 antibody. You'll see that patients were more likely to have disease progression, though, on the immunotherapy as well. But overall, there was a benefit to starting with the pembrolizumab. So this is looking at the duration of response. Among patients who responded, the duration of response, you can see in the green line, is quite prolonged. So most patients are maintaining their response, well beyond 3 years even, which is something we never see with chemotherapy. This is for first-line treatment, but we do have the option of using pembrolizumab, nivolumab, and ipilimumab and nivolumab for subsequent therapies for patients who ended up with chemotherapy first. Next, please. I'd like to take us through a little case now illustrating these principles. So we have a 73-year-old woman who had a cecal adenocarcinoma found on routine screening colonoscopy. She had no metastatic disease. Actually, Dr. Steele performed her laparoscopic right colectomy years ago, and she was found to have a T3N0 poorly differentiated adenocarcinoma, no high-risk features, and she was found to be missing expression of MSH2 and MSH6. So she had abnormal mismatch repair. So, looking at this, she should have had an excellent prognosis. We'd estimate very low risk of recurrence, and we typically don't treat these patients with adjuvant therapy. So she didn't receive any. But then she subsequently had a rise in her CEA about 9 months later, and 13 months after resection, she was found to have pelvic nodularity. Her CEA was high at 58. Biopsy confirmed the recurrence, and she was RAS and BRAF wild type. She didn't have any other targetable mutations. She was started on the standard treatment of that time, which was FOLFOX and bevacizumab. She had 3 months and then went on to 1 month of maintenance, 5-FU bevacizumab, and then already had disease progression. And so at that point, she had, as you can see in the top row of pictures, significant nodularity, significant carcinomatosis in the anterior abdomen, and especially in her pelvis. She went on pembrolizumab with a plan for treatment for 2 years. And we ended up stopping a few months, 3 months short of 2 years, because she developed some mild immune diarrhea. And now, just over a year and a half off of all treatment, her scan still looks like the bottom panel where she's had a clearing of this carcinomatosis. So, this is amazing. We never see these sorts of responses with chemotherapy. And that's why we want to make sure all patients are tested for mismatch repair so that they could be treated with this now up front.
Smita, can I just interrupt you right here and just kind of get a little bit of background? So when patients present with metastatic disease in this setting, does it matter at all when you're making a choice in terms of, hey, if it's carcinomatosis or if it's isolated to liver, or if, we're calling Dan and taking a look and seeing if it's in the lungs? I mean, does the location of the metastatic disease matter at all, or have you seen a sustained response no matter what? Or is there one that's maybe a little bit more a worse prognosis or a better prognosis than the other?
Do you mean for the immunotherapy, Scott?
Yeah, absolutely.
Okay, yeah, so it's a great question. I'm not aware of data indicating that site of disease predicts for response. In this keynote study, there was a suggestion that the patients who had KRAS mutations may not have as good of a response, but it is approved for all patients who have abnormal mismatch repair. Certainly, there's that percentage of patients who progress early on. So I think if you're worried that this patient absolutely needs a response and we can't take a chance with progression, I might start with chemotherapy in that sort of patient, or be nice to see if we could get approved immunotherapy with chemotherapy, that would be ideal. But otherwise, we could use it for any site.
Fantastic. Back to you on your talk.
Okay, so we were moving on to look at this triplet chemotherapy, FOLFOXIRI, because I feel like we do need to think about this more and use it more. I think it's underutilized. So this is a very nice randomized trial done by the GONO group from Italy, which randomized patients with first-line initial metastatic colorectal cancer to start with FOLFOX, bevacizumab, very commonly used, and then go on to maintenance, 5-FU-bev, and then introduce FOLFIRI-bev upon disease progression. So sequential FOLFOX versus FOLFIRI versus starting with the triplet FOLFOXIRI, which is just what it sounds like, 5-FU, oxaliplatin, and irinotecan at almost all full dose, and then maintenance 5-FU bevacizumab, and when the patient progresses, then reintroduce the FOLFOXIRI. So this is really to definitively answer the question with bevacizumab, which is better, starting with all three or sequential treatment. And what they found in this study is that starting with the triplet led to improved survival by 5 months. The median survival was 27 months with the triplet versus 22 months with the sequential treatment. And this was a high-risk group of patients. They were generally unresectable and a lot of RAS mutations in the group. This benefit comes at a cost, though, as not unexpectedly. There was increased severe diarrhea, neutropenia, and neurotoxicity with the triplet regimen, using it up front and then reintroducing it. But I think this is important to keep in mind for our patients who are fit enough, where we do need a response, to consider the FOLFOXIRI. Okay, so just a slide on RAS mutations. This is a bane of our existence. RAS mutations are present in just about half of patients with colorectal cancer, most commonly KRAS G12D, and this has been undruggable all these decades. There has not been a single drug that can target this oncogene. When we see a patient who has a RAS mutation, we know that anti-EGFR antibodies are not going to work. So that's why it's important to know this up front. Finally, we have one candidate drug from Mirati Pharmaceuticals. This is this MRTX1133. They've just announced this year that in preclinical studies, this drug is inhibiting KRAS G12D. So they're launching clinical trials this year. So that's definitely one to watch. And then a rare KRAS mutation G12C, I'm hearing a lot about in lung cancer because these inhibitors, sotorasib and adagrasib, have had excellent efficacy in lung cancer. In colorectal cancer, G12C mutation, the benefit is more muted, low response rates. As you can see here, this is the graph for sotorasib, 7% response rate. Over 70% of patients had disease control. And there are multiple other agents in development. So this is an option for these rare patients with this mutation. We're moving on to BRAF V600E, which is thankfully not too common because it is a bad actor. It occurs in 5 to 10% of patients with colorectal cancer, more commonly seen among right-sided tumors, older female patients, white patients. This is more likely to cause peritoneal metastases and distant lymph node metastases, so incurable metastases. And it is associated with methylation of MLH1 and MSI-H status. It is a poor prognostic marker. So CALGB 8045 was a big US study of first-line chemotherapy for patients with RAS wild-type colon cancer. And it had, in that study, a median survival of 30 months. But when they looked at the survival for those with the BRAF V600E mutation, it's only 17.4 months, so significantly reduced. If you look at this top figure here, it's looking at the signaling pathway. So EGFR signals to RAS, which signals to BRAF, onto MEK and ERK to drive proliferation and survival. And unlike in melanoma and colorectal cancer, if you use just a BRAF inhibitor, it doesn't work because you get compensatory signaling through the EGFR, through RAS, to keep this pathway open and running. So one has to inhibit EGFR with an anti-EGFR antibody like cetuximab or panitumumab, and also adding in a MEK inhibitor has been found to be beneficial. The Beacon trial was a large randomized trial that looked at RAF inhibitor encorafenib with EGFR inhibitor cetuximab, and found that this doublet improved response rate and overall survival compared to chemo for these patients with this BRAF mutation. The doublet actually worked just as well as triplet EGFR, BRAF, MEK inhibition for survival. So now the doublet is what's FDA approved, and that's what we're using. We participated in that Beacon study, and we will be opening the Breakwater trial, which is opening later this year, which will be looking at this doublet as first-line treatment compared to doublet plus chemo versus chemo bevacizumab. And so looking forward to that. We have to consider BRAF V600E when looking at patients who are candidates for metastectomy, because this does affect their outcome. And so there's a data set I'm showing here that's an international data set, including Cleveland Clinic patients of about 850 patients who underwent liver metastectomy with curative intent. About 4% had the BRAF V600E mutation, and this mutation increased the risk of death by 10-fold, more than having extrahepatic disease or a KRAS mutation. You'll see there's a graph here that shows the survival. The dark green is with RAS and BRAF wild type, gold is with a KRAS mutation, and then the blue line at the bottom is the patients with the BRAF V600E mutation. There are many agents that target HER2 amplification in colorectal cancer. So we don't have an approval yet, but it should be coming. There, it's not just breast gastric cancer anymore. As you can see, there are many trials with trastuzumab, with small molecule inhibitors, or with pertuzumab antibody, or with chemotherapy payload. That's the trastuzumab deruxtecan, which is now FDA approved for gastric cancer. And we're waiting on the results of the ongoing SWOG 1613 trial. And my colleague Sunil Kamath, who's on the panel, has opened a trial here of trastuzumab tucatinib and oxaliplatin for GI cancer. So we're excited to enroll to that because the tucatinib looks quite efficacious. And it's important to remember when you're going to treat somebody who has a HER2 amplification that this treatment only works when the RAS gene is wild type. There's a graph from the MyPathway trial looking at survival of patients with trastuzumab, pertuzumab, who were HER2 amplified by RAS. Okay, so you can see that the survival is far worse for those who have a RAS mutation. So HER2 targeted therapies only work when the tumor is RAS wild type. And then moving on, next slide, please. Last topic, PI3 kinase mutations. You know, there's no approved drug for this, but we do know it's an oncogene that's activated in 20 to 30% of colorectal cancers. And work at Case Western Reserve, which we are affiliated with through the Case Comprehensive Cancer Center, has found that colorectal cancers with this mutation rely more on glutamine than glucose for their nutrition. And they upregulate enzymes that allow them to metabolize glutamine. CB839 is a glutaminase inhibitor, so prevents this utilization of glutamine. And work at Case has shown that CB839 with capecitabine can lead to tumor regression in xenograft models and when there's a PI3 kinase mutation. And we've done the phase 1 study, and a graph is shown here showing improved progression-free survival among patients who carry the mutation. The combination is very well tolerated, and we have an ongoing phase 2 study that's funded by Stand Up to Cancer and our GI SPORE. The key points for patients who have deficient mismatch repair, we can use pembrolizumab first line. We do have second line immunotherapy options for them as well. Remember, FOLFOXIRI bevacizumab can improve overall survival compared to sequential doublet therapy, but with increased toxicity. BRAF V600E mutation is a poor prognosis mutation, leads to decreased overall survival even with curative intent liver met resection. The doublet encorafenib cetuximab is effective second-line therapy. HER2 targeted therapies should be considered for the RAS wild-type patients with a HER2 amplification, and tumor genotyping is needed to identify other mutations for which there can be clinical trials. And thank you for your attention. I'm happy to answer any questions that come up in the chat or at the panel.
That's great, Smitha, and thank you so much. Now I know I didn't become an oncologist. I can't pronounce half of the drugs, so that's incredible that you're able to kind of get through that stuff. So a couple of things that have come out. So I'll bring in Sunil here. So Sunil, are we at the point right now where immunotherapy is standard of care for these MSI-high tumors, or is this just something that is on trial only, or where are we at right now?
Yes, that's definitely standard of care now for first-line patients that are deficient in MMR or MSI-high. I would say, as Dr. Krishnamurthy brought up, I think we do have some concerns for that 29% that had upfront progressions. I think, it's important to think about the patients in terms of what their disease burden might be. There are trials ongoing looking at the combination of chemotherapy with pembrolizumab. So I think, there may be certain patients that you may want to still do that combination, even though that's not really been studied thus far. It's an active trial, but I think that's an important consideration. For someone who really needs a response in the next month or two, you may want to combine chemotherapy with the pembrolizumab.
And that's great. Smitha, could you comment? We have people from all around the world on this event tonight. So is genotyping a standard part of this, or is it, do you have to ask for this, or where are we at in terms of that? How do we go about this? And if it's not, is it something that should be requested? Is it really driving home, like you say, a lot of the choice of the treatment therapy? Where are we at?
Yeah, that's a great point, Scott. So, routinely, I think hospitals are, of course, looking for mismatch repair and RAS and BRAF, but we do recommend genotyping for all patients with metastatic solid tumors, and I think that is going to become standard of care. We're seeing that it is useful in selecting patients for clinical trials, and there are studies reporting improved outcomes when you select patients for trials based on genotyping. It is covered by Medicare here in the US. So, and these companies that do the genotyping tend to just take what they can get from the commercial insurance. So we really haven't had a problem with that for our patients here.
Fantastic. And just for time purposes, yeah, go ahead.
Sunil, just, with your expertise in the HER2 targeting, like if you didn't have your study with the tucatinib, and you had a patient with HER2 amplified colorectal cancer, how do you decide which agents to try?
Yeah, great question. It's becoming a busy space for sure. I think, we're really excited about the tucatinib study that we have. I think it's, particularly potent inhibitor of HER2, has a lot less toxicity in terms of EGFR because it's more selective. So it's looked very impressive in breast cancer. So I'd say that to me, that and then the other one you mentioned, trastuzumab deruxtecan, I think both are extremely exciting. Trastuzumab deruxtecan in particular, I think, or TDXD as we refer to it sometimes, has shown quite a bit of efficacy in patients who've had HER2 therapy previously in other diseases, which is not something that we would see in gastric cancer, for example. Every agent that was tried after trastuzumab was a negative study. But this agent in particular still had around a 40 to 45% response rate even after people had received prior HER2 therapy. So it seems to be particularly effective. It does come with the price. It's a rather toxic agent for sure. And ILD is definitely something to watch out for with that particular drug. So I think for the select patient who I think really needs a good response, that may maybe go to as well.
Well, that's fantastic. And just for time purposes, I'm going to point both of our oncologists to the chat box to please address the questions, and please keep those questions coming in the chat box. He'll be able to do that. It's my pleasure now to reintroduce my partner in crime, Dr. Michael Valente, he of the fake plant in the background. And he's going to talk to us a little bit about metastatic colorectal cancer and cytoreductive surgery and HIPEC. Mike, turn it over to you.
Thanks, Scott. It's actually a real plant. It needs some water, though, so I'm going to make sure we water that after the meeting here. So thanks again. We're going to move on to some surgical management. We just heard a great talk on all the new and exciting drugs and new treatments, but things still may need a surgical intervention at some point. Hopefully someday all these new medications will maybe render mastectomies obsolete, but until then, colorectal peritoneal metastasis, really unknown incidence, 2 to 50%. At some autopsy, up to 20% will have metastatic disease, 48% with mucinous. Folks present with 5 to 10% as a synchronous metastatic to the peritoneum, and about 15 to 30% will be metachronous down the road. So what are some of the risk factors for peritoneal spread? T4 tumor, large tumor, perforated tumor, poorly differentiated tumors, mucinous histology, signet ring cell histology, which is a very bad actor, and of course, emergency surgery, obstruction. Colorectal peritoneal metastasis. So historically, 5 to 7 months with the standard old-fashioned chemotherapy. However, modern, quote unquote, modern, this slide's a little old, of course, or these papers are old, but 16 months is about the average for stage 4 disease to the peritoneum. Liver, you can see, is about 19 months, lung, 25 months or so. Now, this is, the modern chemotherapy, meaning the FOLFOX type of backbone regimen that we use. This is a paper from 2012 now from out of Mayo. And 2,000 patients all received chemotherapy. These are peritoneal disease. Median overall survival, 12.7 months. With FOLFOX, you can see about 16 months, 4.2% overall survival at 5 years. Now, obviously, Dr. Christian Murthy's talk just touched upon many of the new drugs and treatments, so hopefully these numbers will change over time. So isolated peritoneal metastasis, this is what we're talking about. The term carcinomatosis I like to use only in certain situations. That is a diffuse involvement of the visceral and parietal peritoneum. This is an inoperable end-of-life terminal event. This is not the patients that we would consider for cytoreductive surgery and HIPEC, not at all. But what we are looking at are these 4 to 8% of folks who have isolated or limited peritoneal disease without any other systemic metastases, so just confined to the peritoneal cavity. This is a highly select group, and this forms the basis for offering aggressive surgical treatment in modern times. So cytoreductive surgery and HIPEC over the last 15 years has really been a vast evolution for colorectal cancer metastases. It's been around for much longer than that, but over the last 15 years, many research publications have come out, and it's taking off throughout the world. There is a chance for potentially resectable patients to undergo an operation if they are progressing on chemotherapy or not getting the response that we saw in the last talk. There's lots of data out there, but it's mostly retrospective in nature, large case series in the hundreds to thousands, and there's very few prospective trials, which makes the discussion a little more complicated because not everyone agrees with the philosophy of cytoreductive surgery and HIPEC. However, in specialized centers, in certain papers, a cure, I don't like to use that word very often at all with my patients, but a cure potentially in up to 15%, meaning no disease after 5 years. Albeit this is not that common, and this may be inflated from this particular paper, but there is a chance out there. Those who perform it do believe that we can potentially cure. Not very common though. So what's the rationale? So traditionally we perform the cytoreductive surgery and the HIPEC together. We do the cytoreductive part, meaning we're taking out all the gross disease, peritonectomies, visceral resections, all the things we could see and feel will come out. And then of course, if you understand the peritoneal disease, it's generally speaking, it's not just going to be a mass here, a mass there. You must conclude that there's probably going to be microscopic disease left behind that we can't see. So what the chemotherapy portion does, the hyperthermic chemotherapy, is hopefully it's a 1-2 punch. We get the gross disease out, and then we can wash the abdominal cavity with hot chemotherapy to clean up any cells that may be remaining. So why the HIPEC does increased penetration of the chemotherapeutic agent. Our agent of choice is mitomycin C at the Cleveland Clinic. The hyperthermia itself has a cytotoxic effect, and overall systemic toxicities are decreased due to the drugs getting to right where it needs to go. It's not getting into systemic circulation for the most part. And like I said, direct treatment of the free intraperitoneal cancer cells. So how about prognostic factors and case selection? Is it for everyone? Of course, it's not for everyone. There should be a very strict selection criteria. Obviously, they have to have good performance status. We've performed HIPECs on folks in their late 20s and early 30s up until their early 80s. So age in this by itself is not a distinct number for cutting off, but how well is their performance status? The extent of peritoneal disease is one of the most important aspects of the workup for these patients, and we'll go over that. The PCI, meaning the peritoneal carcinomatosis index, should be less than 20. Some say 17 in other centers. And really, what I want to get at is, can I, as the surgeon, resect all the gross disease out there, meaning a completeness of cytoreduction score of 0 or 1, meaning taking things down to the 0.25 millimeter gross status, because anything less than 2 millimeters, the chemotherapy could handle theoretically. So what's going on with the PCI? And as a surgeon, do I think I could reasonably get everything out with minimal and acceptable morbidity? Here's just a quick example of the PCI. Breaks up the abdominal cavity into 13 different quadrants. We use this very often before every case and after every case to give the PCI. So this completeness of cytoreduction score, you can see here CC0 and CC1 are equivalent, 0.25 centimeters or 2.5 millimeters. So really the CC0 is like an R0 and CC1 is like an R0, but the CC2, now we're talking about R2 type of resections. Anything less than a CC0, CC1 should not be done. You should not carry out the operation if you can't get everything out. You should stop. And here's just a Kaplan-Meier showing that anything less than a CC1, 0 or 1 has obviously decreased survival. Pre-treatment evaluation, CT, MRI, PET, all of them are equally good and equally not good. About 75% will pick up lesions that are at least 1 centimeter in size. Anything less than a centimeter, especially a half a centimeter and less, it's getting increasingly difficult to pick up on any of our modalities that we have. None of them have proven to be better than the other. They can be complementary to each other, but this is one of the vein of our existence for pre-op imaging. It always underestimates what we find out inside. Full colonoscopy, CA levels, histological review, important signet ring cell features, mucinous features. As Dr. Krishnamurthy said, all of these markers are extremely important as well. Tumor board consultation, it has to be done to get a full discussion with all the team members. And then we like to do diagnostic laparoscopy if feasible on many patients to get a laparoscopic PCI to see really, am I going to take this patient off chemotherapy and do a big incision? Or rather, can I make a small incision if feasible? Many of these people have had surgery before. Small incision, mini laparotomy, get a good look and say, you know what, we can do it or we can't do it. And then if we can't, we get them back to chemotherapy right away. So as I said, diagnostic laparoscopy, minimally invasive, laparoscopic PCI, shortens delay in chemotherapy. Can be difficult, as I said. Most of these folks have had surgery already. Here's a couple of views in the pelvis and of the abdominal wall here. This is the right lateral abdominal wall. This is something that is resectable with a peritonectomy, and this is where we really get our good view of what's going on in real time with the patient to avoid unnecessary laparotomies. Here's the chemoperfusion setup. Here's a quick diagram here on the right, and of course we have our inflow and outflow catheters, our reservoir with chemotherapy about 105 to 108 degrees Fahrenheit. I particularly here would like to use mitomycin C, 30 milligrams over 60 minutes. Then we do an additional 10 milligrams over 30 minutes for a total of 90 minutes, an hour and a half of 40 milligrams of mitomycin C. Other regimens do exist, lower dose mitomycin, and then especially in European literature and practices, oxaliplatin is used for 30 minutes. I will say that there is no standard regimen. There is no standard worldwide consensus on the duration or the drug delivery system or the drug being used. So there's a lot of different thought processes out there, which makes literature and research difficult because there's a lot of variability and heterogeneity. Morbidity. This is a ACS NISQIP study of over about 700 patients. You can see overall mortality low, re-op late 10%, 30-day readmission 11%, and length of stay about 13 days. These are right in line with most other major abdominal pelvic operations. I would say in our experience here, I don't have the data for you, but patients, they do quite well. The vast majority, about 70%, go directly to the regular nursing floor, not to the ICU. So acceptable morbidity in experienced hands and centers. Briefly, some of the basis for this comes from one of the Dutch randomized controlled trials. Peritoneal metastases from colorectal or appendix, 100 patients. Either were sent to palliative surgery with plus 5-FU, 51 patients, or they had cytoreductive surgery HIPEC with mitomycin plus perioperative FOLFOX. And what we saw was median survival 12 months versus 22 months. So this is one of the bigger papers that has a randomization. As I said, though, a good randomized trials are not that common, and more are being done, as we know, and we'll discuss some of them. They did an 8-year follow-up on that same paper. Median progression-free survival, 8 versus 13 months, 13 months for the cytoreductive surgery and HIPEC. And then 5-year survival, 45% in patients who in R1, essentially a CC1 was achieved. So they did show benefit, definitely with a cytoreductive part. Now, as I'm going to get to, is it truly the addition of chemotherapy, or is it the good cytoreductive surgery that is helping us get these results? We don't quite know yet, but we'll talk about that next. Here's a look at HIPEC versus modern chemotherapy, and this is from Elias from Journal of Clinical Oncology in 2009. 48 patients in both arms, median survival, and this is a retrospective review, 24 versus 63 months, 5-year survival, 13 versus 51%. Now, none of these papers are perfect, and they all have their flaws. Other multi-center in support of HIPEC, we have 600 patients in both, showing overall median survivals 30 months, 41 months, 5-year survivals up to 58% in some series. And you can see here, this is a collection of some of the papers in support of chemotherapy, showing that 5-year survival rates could be quite high if a good cytoreductive surgery was performed. I want to hint at that one more time. A good debulking procedure should be done, and that's what's giving us these longevity potentially. This is a paper that's been being talked about for the last several years. It was finally published in Lancet Oncology just this year. This is the Prodigy 7 trial out of France. This is a multi-center randomized open label phase 3 trial looking at potentially resectable peritoneal disease. Their PCI had to be less than 25, quite high. And they had to decide if they could get cytoreduction or not complete. If they thought they could, they were randomized into the HIPEC arm, which received 30 minutes of oxaliplatin and then systemic chemo to follow, versus the no HIPEC arm, which just received systemic chemo. Both groups received complete cytoreductive surgery. One group got HIPEC, one group did not. As I said, 265 patients, many years to compile the data, as I discussed. Mortality 1.5%, morbidity no difference between the groups. A little bit more morbidity in the HIPEC group, very significant, 24 versus 13%. Median follow-up of 63 months. Overall survival, about the same. So HIPEC versus no HIPEC, about the same. But a subgroup analysis was performed, PCI of 11 to 15, which is the vast majority of my patients. A lot of my patients are in that range, and they did show a benefit of 41 versus 32 months. This is not talked about very often, but this is a little subgroup that is important. And this does include a large group of patients that we would operate on in that PCI range. So what did it say? The completeness of cytoreduction is probably the most important prognostic factor. However, oxaliplatin is not a universally accepted agent. We don't use that here in the States. Many folks have been on oxaliplatin through a systemic approach, and many people have become, not effective on them. So oxaliplatin may not be the best drug. Short HIPEC time of only 30 minutes. And of course, we need more prospective trials looking at mitomycin C head-to-head with oxaliplatin potentially to see really if the HIPEC does offer any advantage. Moving quickly to prophylactic HIPEC, this may seem like an odd topic, but if you have limited synchronous peritoneal mets that are completely resected at the primary tumor surgery, you could consider it. A large T4 primary cancer, T4A, T4B. I see this quite often, isolated synchronous ovarian mets, Krukenberg tumors in these females, which chemotherapy is notoriously not effective for. Tumor had a perforation at the primary operation. Peritoneal cytology on cytology. Mucinous primary tumors. So any one of these, they have looked at these. There's multiple trials going on. Just recently, 2 out of Europe have concluded. They have shown no difference in disease-free or overall survivals. However, there are 3 more trials internationally going on right now, 1 from Spain, 1 from Italy, 2 from Italy, excuse me, and they're looking at this. Now, in our practice here, I would say the female patient who had a right colectomy now has a Krukenberg tumor 6 months later. Chemotherapy, it keeps getting bigger. Those are definitely patients I would take for a debulking. I would take out the ovaries, and we do omentectomy. And very often you're going to find cancer cells in the omentum, in the peritoneal cavity. So these are folks that I would give prophylactic HIPEC to if I don't see any other peritoneal disease. I think our data is not out yet, of course, but I think this is one area we may be able to help people before it becomes inoperable. HIPEC, briefly, not FDA approved. I know we have a lot of people on the line from across the world, and it is being done widely in Europe, South America as well now, Latin America, and Asia. The Food and Drug Administration, we have a phase 1 trial undergoing right now. And essentially what this is pressurized intraperitoneal aerosolized chemotherapy in conjunction with systemic chemo. Initially used solely as a palliation method. It can be done every few weeks, every few months, multiple times. Laparoscopic approach, you can see in the upper right there. We inject high pressurized chemotherapy, and you can see some before and after pictures here. And however, now instead of just for palliative purposes to prevent maybe large or small bowel obstructions, malignant obstructions, they're using it now to downstage folks who may have not been a HIPEC candidate, who have gotten HIPEC, who have decreased their tumor burden, and then we could potentially go in and do a cytoreductive surgery in HIPEC the traditional way. More to follow on this. It's getting a lot of steam throughout the world. Still phase 1 trial here in the States, though. Very briefly, an algorithm I borrowed from Dr. Brendan Moran from Basingstoke in UK, who does a vast majority of all the United Kingdom's peritoneal malignancy program there. So you have a colorectal peritoneal metastases. If found in the metachronous, later on, and I'll get to that, those patients should be referred to centers that have experience with HIPEC, cytoreductive surgery, or at least a phone call to one of those folks who can help get you the right pathway. Now, you're at the operation. It's a synchronous disease. You find out during the operation. This is important for everyone who doesn't do HIPEC surgery. If there's limited disease, we actually recommend that you leave everything alone and then refer to us so we can do all one operation at the same time. If there's a impending obstruction, something bad going on, do as little as you can. Bring up an ostomy, resect if you have to, but do as little as possible. Take biopsies, explore disease extent, meaning get a PCI if you can. Try to figure out how much truly there is. But really, do as little as you can. That's not gonna, unless they need it for obstruction, etc. And here we are now with I'll go back to the metacrinus one here. If it's been less than 1 year and they've had new metastases, I think many of us would say they need chemotherapy, and let's reconsider something down the road with restaging. If it's been more than a year, and they could go right to cytoreductive surgery and HIPEC. I also like to highlight this algorithm from the Chicago Consensus, which has excellent review articles and algorithms on metastatic disease of the peritoneum on all cancers, not just colorectal, in Annals of Surgical Oncology from last year. So please, December of 2020, please take a look at this. It's a very nice algorithm. Some take-home points. It may benefit a highly select group of patients. Low burden of disease, completeness of cytoreduction is the most important prognostic indicators we have today. Addition of HIPEC is and may be beneficial in very select patients. Ideal drug regimens are yet to be determined. Potential increase in survival for well-selected patients for at least a couple years. Cure maybe in select patients. Acceptable morbidity, and early referral to a peritoneal malignancy program is encouraged. And of course, ongoing trials are going, a lot of data going on. Looking forward to see what's going to happen in the next few years. Thank you.
Yeah, well, thank you, Mike, and I appreciate your opportunity to, after you promised me you'd be done in 10 minutes. So that was a quick 10 minutes. The time just flew by. So 2 quick questions to go for you. First of all, one of the questions is that if you get in there and there's just a very, very small, like a little bit of jelly, maybe down in that right lower quadrant, is that something that needs HIPEC, or can we just scoop that up and just monitor these patients and go from there?
Yeah, very common. Definitely get it out. If it's part of the operation, a little bit of mucin, get it out. We'll send it off for pathology, of course. In my opinion, those patients would be a good setup for HIPEC. Maybe not at that particular time, of course. I like to get the full pathology, see what's going on. But that is definitely someone I would definitely want to take a look at with a laparoscope in the future. Many of those patients would go on to chemotherapy if they have lymph nodes, of course, or the presence of cancer cells in the mucin would dictate chemotherapy. So I would give them chemotherapy, come back down the road and put a scope and take a look.
I'm going to give a second question to both Dan Raymond, our thoracic surgeon, as well as Smitha. And I would say, if you have somebody who has very, very low volume abdominal carcinomatosis, something that we can take care of, guaranteed, and also has maybe one lung lesion, is that person somebody that would be better served, Dan, by you taking out that something with a thoracic wedge, or would that person get chemotherapy? How would you work through that? Dan, I'll ask you first.
That's a tough question. I think it kind of the role of pulmonary metastasectomy is evolving, and the original kind of the golden rules of pulmonary metastasectomy is complete control of disease at primary site of disease, all diseases resectable with no residual tumor left, and really that golden rule has been liberalized to now kind of major societies are saying if you can feasibly control every site of disease. Now, to me, that's the big question remains, can peritoneal disease be reliably controlled so that you are giving this patient a reasonable chance of and I think that's where, in a sense, you need to have a multidisciplinary team that sits down and talk and goes through all of these variables, and you have each expert state their point. And if Mike came to me and said, I can control this, I would be more than happy to put them through a wedge resection. To me, it makes most sense that systemic therapy always comes first, because that's what's probably the most likely going to prolong their life. But if I can provide local control in their chest as part of a holistic approach that includes all sites of disease, then I would be willing to do that. And I think many thoracic surgeons would. I hope that was under 10 minutes.
Fantastic. No, that's perfect. Smitha, I'm going to cut you off just because I noticed the time, and we're going to welcome in Dr. Federico Acego, who is the director of our liver cancer program. And Federico is going to talk us a little bit about emerging surgical therapies for a difficult problem, and that's the colorectal cancer liver metastases. So Federico, thank you.
Thank you, Scott. Thank you so much. Okay, so I will be focusing about liver transplantation, actually. So there are a number of evolving options for the treatment of these complex patients, and liver transplantation as an indication is emerging in the new era, and you'll see why I say that. So just to put in context, again, to emphasize the importance, the ongoing importance of surgical interventions for patients with colorectal cancer liver metastases. Surgery continues to be the mainstay therapy over time. As you can see, these slides from 2011, we're at 2021, and this continues to be the case. So when we specifically look at transplant and we look before 2000, we see that this is not a novel indication. It was attempted before, but it was abandoned because of the poor outcomes. But those were related more due to technical complications because transplantation was in its infancy. This is late 80s, early 90s. After that, after 2000, there was a small pilot study with 21 patients from the University of Oslo that could show that the outcome in better selected patients could be in the order of 5-year survival, overall survival. And then there were other studies and follow-up studies from the same group that we will look into. In terms of the selection criteria, these are pretty straightforward, but essentially patients presenting with resected primary tumor, good performance status, a minimum of systemic chemotherapy to observe the response to the treatment, and absolutely absence of extrahepatic disease. That is, at all times metastases have to be limited to the liver, and the absence of some specific biomarkers such as BRAF that have, as we know, a more aggressive behavior in general. And then also more importantly, we can see it has to be some time between the removal of the primary time of diagnosis before the time of consideration of transplantation. That is very important as one of the predictor factors, as we will discuss. So here the survival rate on this first small trial that I mentioned for University of Oslo. You can see the 5-year survival of 60%. And when we look at the recurrence-free survival at 3 years was 0%. So with this initial experience, we observe that most of the patients are expected to have at some point a reoccurrence of disease. However, what was seen is that at the 10-year follow-up on this same cohort, there was a number of patients, 40%, that had less than 2 poor predicting factors. They were alive. And these factors were defined as the Oslo score factors. And these are, you have them on the right upper corner of the screen: maximal tumor diameter of 5.5 centimeters, pre-transplant CA levels more than 80, progression on systemic chemotherapy, the interval between diagnosis of the primary and resection of the primary, and consideration of transplant less than 2 years. And then, as you can see, the patients who had 2 or less of these bad score points had better and could achieve actually prolonged survival after transplantation. And keep in mind that these patients had no other alternative options at that time. Another factor to consider, negative factor that was observed, that patients presenting with primary tumors from the right colon did worse compared to the rest of the locations. And this is the second trial, came after from the same group, the SICA-2 study. And here they transplanted 15 patients. And you can see that the survivals were much better compared to the first study. So overall survival, 5 years, 83%. And look at this disease-free survival at 3 years, 35%. So this study showed that we can achieve no evidence of disease, at least at the midterm follow-up. And this is very important. And we will see why was that. Now, when we compare the characteristics of the cohorts between the first and the second study, both groups, of course, were considered non-resectable, and these were evaluated by multidisciplinary teams with transplant surgeons and hepatobiliary surgeons. But the SICA-2 study patients had, at the time of transplantation, less amount of burden disease in the liver, And this was because of a combination of more aggressive local regional therapy before transplantation, and selected the patients who responded better to the systemic therapy, essentially. And they use PET scans, you can see, to evaluate right before the time of transplantation the metabolically active burden of disease. And this is a very, very, very important evolution of the selection criteria. So then around 2017, we modeled our own protocol here at Cleveland Clinic. We were the first center in the United States to do this. These inclusion criteria were modeled around the Oslo University criteria with some adjustments. One of them is that we favor the use of living donor liver transplantation for the patients who had no or minimal portal hypertension. Keep in mind that most of these patients can present without portal hypertension. For those patients presenting with cirrhosis and portal hypertension, we favor the use of deceased donor transplantation. These are the patients who are exposed to extensive toxics and prolonged systemic therapy and local regional therapy. And again, we incorporate the use of heavy pre-transplant local regional therapy to get to the point of transplantation with no or low active volume, metabolically active volume disease before the transplant, evaluated by PET scan. Next one, please. So now I'm going to share with you 4 cases. This is a young patient with right colon cancer with synchronous liver metastasis. You can see obviously non-resectable disease in the liver. She undergoes systemic therapy with a great response, as you can appreciate. So the patient undergoes a first-stage hepatectomy with multiple wedge resections, and that is followed by right portal vein embolization in preparation for right hepatectomy. And at the same time, this patient received implantation of the hepatic artery chemoinfusion pump to receive in the adjuvant setting both systemic and pump chemotherapy. So you can see this is after the second stage hepatectomy, left low without radiological evidence of disease in the liver. Unfortunately, this patient suffered toxicity to the biliary system. This is a well-known potential complication of the fluoxuridine hepatic artery pump infusion. And this is what the patient had, and developed complications related to cholangitis, infections, and so on, and therefore needed a transplantation. So patient underwent live donor, a left lobe liver transplantation in 2018. You can see how yellow cholestatic the liver is before and then the healthy new liver after the transplant. She had a total of 2 negative factors, and this is what's very, very important. On the explant, there was no residual metastatic disease in the liver. So this is a case where the damage caused to the liver from all these treatments is what drove the need for transplantation, other than the actual presence of a metastasis. But remember how much disease this patient had, how the big burden of disease the patient had 3 years ago. Actually, it is today is 3 years since she was transplanted, and no evidence of recurrence disease at this point. This is a second case. Young patient, sigmoid cancer, synchronous, advanced, unresectable colorectal mets. And you see he was diagnosed in 2012, back in the time. So it's, this is one of the things that we want to see, the more prolonged the time from the time of original diagnosis to the time of need of transplantation, the better. So this patient was able to keep the disease limited to the liver for a long time. Okay, so was diagnosed 2012, underwent systemic therapy, sigmoid colectomy 2013, followed by more systemic therapy and a combination of direct interventions to the liver with ablation, resection, and then also received implantation of the HIA pump and received combination of both systemic and FUDR, and then proton beam radiation for residual treatment of mets. Next one. So no surprise, with all those prolonged toxic therapies to the liver, the patient developed cirrhosis, obvious front portal hypertension, ascites, and again, this is what, high MELD score, this is what drove the need for transplantation more than the presence of metastasis in the liver. You see the pre-transplant PET scan, small foci residual disease. So patient went and underwent liver transplantation. Next one with the deceased donor this time because it had a high MELD score and had a total of negative factors and 4 residual foci of disease in the explant, the largest being 1.7 centimeters, so really small amount of disease. A year later, patient gets a CT of the chest, and you see that MET. That MET is amenable to resection. That's what happens, goes back on some systemic, and this patient is about 3 years from the time of liver transplantation with no evidence of disease. What this case tells us is that these patients can have mid-term survival after transplantation, even in the presence of recurrence. Those recurrences that are more benign are like these ones, unifocal in the lungs that tend to be slowly progressive, even under immunosuppression, but that can be tackled through radiation or resection. Another case, and this case illustrates to us the importance of aggressive locoregional therapy before transplantation. Look, the massive amount of disease this patient has in the liver. Diagnosed in 2017, sigmoid cancer, synchronous Mets, received systemic therapy. And look at this, 4 rounds of 190 radio embolization, and then undergoes living donor liver transplantation in 2020, about a year of this, and he had a total of negative factors of 0, and these are the Oslo criteria, if you remember, and the explant show only 1 foci residual metastasis of only 4 centimeters, so comparing with how big was this at the beginning, is a pretty good response. You can see the 4 rounds of embolization destroy the tumor, but also destroy the liver. So the patient develops cirrhosis, develops ascites, and that's what happens. Once you cross that line, you know that patient has no option but to get a liver transplantation. So you have to be sure that the patient will be a good candidate. You have to be sure that it responded well to the systemic therapy, to the other local regional therapies. You have to be sure there's no obvious evidence of extrahepatic disease. And this is the PET scan right before transplantation. You can see minimal active, metabolically active disease before transplantation. So this is an important case, and this is the first one we did, and this is the case to avoid. Young patient, sigmoid cancer and synchronous liver metastasis, underwent sigmoid colectomy in 2016, and then went on systemic therapy, clearly non-resectable in the liver. So this patient had a good response to systemic therapy, but the pre-transplant PET scan shows still a quite active, the presence of quite active disease. And this is the mistake. If we had the same case today, we could do, heavy Y90 to see the patient, the tumors downstage before the transplantation. So the patient received left low live donor 2017, had total negative factors of 2, and on the explant, no surprise, multiple foci of live active adenocarcinoma. 6 months later, multifocal recurrence affecting both lungs and lymph nodes in the abdomen. So clearly, this you cannot target other than with systemic therapy, and the patient died 2 years from transplantation. So this is a summary. For some reason, you don't see this. There's 7 patients total we took to the operating room with an attempt for liver transplantation with unresectable colorectal cancer liver metastases. 4 patients are alive, no evidence of recurrence disease so far. The two of the patients with the longest follow-up from transplantation reaches 3 years. 1 patient, the first one is the last one I just saw you, that she developed recurrence and died at 2 years. And then 1 patient died intra-op from technical reasons. It was a super sick patient, multiple previous interventions. Her death had nothing to do with oncological reasons. Another patient in the OR the transplant was aborted because of one of the tumors was invading the diaphragm. that's the summary of our experience here. So when we look at the United States experience, since the so-called MEL era, which is after 2002, we can divide before and after 2017. So before 2017, there were 12 cases registered of transplantation for non-resectable colorectal cancer liver metastases. Those were mainly done for the need of liver failure from the toxicity of chemotherapy. But after 2017, we started seeing transplantations for the indication of presence of active cancer in the liver. So 21 patients and performed and both, done both through living donor and deceased donor transplantation. So this is happening. Is the indication is expanding, as we can see at the international level, but also here in the United States. And this is my last slide. So the take-home points. So first of all, obviously, with surgery, we cannot beat biology. And it is so important that to understand that these are highly select patients. And the equipoise of that, is composed by these three major elements. The biomarkers and the response to the therapy. So CA levels have to decrease in response to the pre-transplant therapies. The response to local regional therapy, as we saw, the metabolically active tumors have to respond to local regional therapy. And the test of time, we have to observe that the patient remains stable after we achieve the response. And of course, absence of extrahepatic disease. And I want to emphasize this because a lot of patients and physicians refer patients to me, and they say, well, I had, when this was originally diagnosed, a small nodule in the lung or a couple nodules in the lung that then disappear on chemotherapy. So most likely were, true cancer at the time. At this point, at least, we're not considering those patients. Looking into the future, evolution of tumor genetic profiling. We don't take BRAF. We know that. When there are superimposed somatic mutations such as SMAD4, TP53, RAS, there's some evidence that patients do worse, but we don't have evidence in liver transplantation. But that definitely will have to continue to be studied. And the role of liquid biopsy, I think, is going to be important to monitor the response to, along with CEA, more traditional biomarkers, to monitor the response to the pre-transplant treatments, but also to monitor the risk of recurrence after transplantation and the need to intervene with adjuvant chemotherapy, perhaps one day. Today, we're not doing that. So with that, I'm going to conclude here, and I wanted to thank you guys for this great event, and I'm happy to take any questions.
So thank you, Federico, and I encourage everybody to use the chat function. I know we are up against it. We do have one more talk left, and I made the command decision. We'll go a little bit over to make sure everybody's there. I do have two questions. We're going to bring in two of our other panelists real quick. First of all, Cristiano, can you talk a little bit about this concern about resecting an isolated metastatic lesion to the liver versus the fear that it goes away on chemotherapy? How do you judge? Should you give the chemo? Should you resect it? What do you do? And how do you guys think about that as hepatobiliary surgeons?
Yes, that's a great question, Scott. So first, we assess size of the lesion and location. I think those are two very important factors when there is a patient that presents to you with metastatic disease and that is chemo naive. I think there are some lesions that are deep into the parenchyma. They're small. There is very little reference landmarks surrounded by by tissue that it's harder to find at a later time. So those patients, I think, should be very carefully assessed for an upfront resection or ablation. And then there are those patients that have very small lesions that are, for instance, in the left lateral segment or in location that you can find even if they disappear or resect anatomically part of the liver. And those patients can be can undergo actually chemotherapy as our approach is for most of the time. Now, I think what is critical is the discussion up front at a multidisciplinary level. That's what I think it makes a difference and prevents from metastatic disease to disappear and then be left with the unknowns.
And Aaron, if you can very quickly, I know this is a topic of grand rounds in and of itself, but what are you've got a lot of trainees on, so if you would say the best lesion that I can use ablation therapy on, Aaron Berber, who directs our ablation thing, what are those lesions? What are those like?
I would say that in our modern time, any lesion that's not amenable to a laparoscopic resection is deeply located in the liver and would require a significant amount of liver to be removed, especially in the pre-chemo period, would be best candidates for an ablation, where you can do laparoscopically, and then next week the patient can go back on chemo and you're not burning any bridges. And also newer ablation technologies are very effective with a very low chance of failure at the treatment site.
Well, that's fantastic, and we're so glad to have the crew with us here. And so with that, we're going to turn it over to our last speaker, and that's Ehsan Balamagwala, and he's going to talk about some of the exciting things that he's doing in terms of, or our team is doing in terms of radiotherapy in the setting of metastatic disease. Many of you may not think about that. So Ehsan, give us a little glimpse into what we're doing.
Thank you so much, Scott. Glad to be here and share some of the really cool, exciting stuff that we're doing. I'll go right into the talk. We're going to discuss utilization of radiotherapy in the preoperative management of metastatic rectal cancer. Spent a lot of time talking about ablative radiotherapy, known in the United States as SBRT, or in Europe and Canada as SABR. Talk a little bit about intraoperative radiotherapy and spend some time talking about oligometastatic disease in the lung and the bone and CNS metastases as well. In terms of low volume metastatic disease patients, it's very important to present these patients at the multidisciplinary tumor board where all the disciplines are present. And if they have limited liver metastases that are going to get resected, at the time of rectal surgery, we will often recommend short course radiotherapy, 5 gray times 5 fractions, to reduce the chance of local recurrence. A lot of what we're seeing these days is recurrent colorectal cancers. And this is a case of actually a patient of Dr. Steele's, 74-year-old lady who had clinical T2N1 rectal adenocarcinoma, underwent TNT with chemoradiation as well as consolidation chemotherapy, and developed an isolated left common iliac lymph node recurrence, which is shown right here on the restaging PET scan. And when we discussed this in tumor board, Scott and others were concerned about this posterior margin, especially along the blood vessels. And so we recommended preoperative SBRT radiation. And this is the plan itself when we draw out all the bowel, the ureters, and the target as well, of course. And what you see here is a low dose bath along the nodal bed, but also with a high dose boost so that that posterior margin, which is the highest likelihood of getting having a positive margin, as well as along those iliac blood vessels, get a higher dose so that it's ablated, so that even if by chance there is a positive margin, it received an ablative radiotherapeutic dose. And so this patient was also, at the time of surgery, received intra-beam IORT. This is a machine that has several spherical applicators, and we decide this based on the size of the surgical cavity, and final pathology on that patient actually showed negative margin resection. And so to date, she is disease-free. Now, switching to oligometastatic disease, this is a really great paper published in 2020 by the European group, defining the different stages of oligometastatic disease. The oligometastatic disease state was initially defined in the early 1900s, but has gained in the last decade or so a lot more prominence as systemic therapies have become significantly better. So this is a paper that I would refer everyone to kind of understand what the different types of oligometastatic disease states are. This was a really great paradigm-changing trial, initially published in Lancet and more recently updated in the JCO, by Dave Palma and his group in Canada, the SABRE Comet trial. What this trial did was it included patients with controlled primary tumors, up to 5 metastases, allowing up to 3 metastases in a single organ, and all sites must be able to be treated with SBRT or SABRE very safely. It was a phase 2 trial, and the primary endpoint was overall survival. It's important to note because this was a screening a phase 2 trial, the significance level was at 0.2. And several secondary endpoints were also included. What the long-term results published in JCO last year showed that with a median follow-up of 51 months, the primary outcome, meaning death, occurred in 73% of the control arm and 53% of the SBRT arm. And what you see here is that the separation on this Kaplan-Meier curve is significant between patients who received SBRT versus control. And the 5-year overall survival was significantly elevated. One of the questions that the trialists wanted to address was if you exclude the patients that had prostate cancer, metastatic prostate cancer, was there still a survival benefit? And they actually continued to find a survival benefit even if they excluded patients with a prostate cancer diagnosis. And so a practice-changing paradigm that's evolving. This group currently has a trial open looking at enrolling patients with over 4 but less than 10 metastases to see if this survival benefit would also be beneficial in patients with more metastases than less than 5. The quality of life was evaluated rigorously, and there was no difference in the control arm or the SABRE arm. And the toxicity was very manageable with very little grade 3 or above toxicity. So these are a couple of cases that we recently treated at Cleveland Clinic. This is a 70-year-old gentleman who underwent TNT LAR in 2016, developed metastatic recurrence in the lung and liver, was started on FOLFOX and Avastin, had a very good response to treatment, and underwent liver resection by our liver surgeons here in July of last year. And then the only site of disease left was this left lower lobe pulmonary nodule. So as is my practice with all lung metastases, this patient was seen by my partner, Dr. Ahmad, in thoracic surgery. We did shared decision-making with the patient, and eventually the patient chose to undergo SBRT. This is the plan that we devised for him. A very ablative dose was delivered to the center of this tumor. And 3 months later, you can see a ablation zone here, and the tumor, as shown by the arrow, is quite small and shrinking already at the 3-month mark. Similarly, we're seeing a lot of patients in our early onset colorectal cancer program. This was a young gentleman, 35 years of age, with sigmoid colon cancer and a bone-only metastasis to the sacral spine. This was deemed unresectable by our neuro and orthopedic surgeons, and so was referred to me for consideration of spine radiosurgery. And as you can see, the disease is right here in the sacral spine, right here abutting the cauda equina. We devised a superb plan treating this patient to 30 gray in 3 fractions. And as you can see, the dose lines bend nicely away from the cauda equina, sparing those nerve roots and delivering an ablative dose to the bony metastasis. So some take-home points. The role of radiotherapy in stage 4 colorectal cancer is continuing to evolve, and it's very exciting as we develop more pathways to implement SABRE or SBRT in the treatment of metastatic disease. And I cannot emphasize this second point enough. Multidisciplinary evaluation is absolutely crucial, and shared decision-making is very important. In patients with low volume metastatic rectal cancer, most of these patients, if not all, should receive short course radiotherapy prior to rectal surgery. In the setting of recurrent colorectal cancer, if the patient is resectable as deemed by the colorectal surgeon, a strong consideration should be made for SBRT preoperatively or BID reirradiation with chemotherapy. to enhance margin control, as well as have IORT on reserve in case the frozen section comes back as positive. And in the unresectable setting, there's emerging data for SBRT for local and pain control from the UK group, and we have been pretty active in this space as well. For metastatic disease, for lung metastases, surgical resection, if appropriate, versus SBRT. And for bone and intracranial metastases, radiosurgery, whether LINAC-based radiosurgery or gamma knife radiosurgery, forms the backbone for treatment in the CNS. And we certainly heard about liver metastases extensively by my colleagues. So with that, I will end this. Thank you so much, and I'll be happy to take more questions.
Well, thank you so much, Ehsan. And truly, I know we're a few minutes over, but my sincere hope is that everybody out there could get a feel for how it really does take a unique team to kind of see all the different aspects to make this a success. And hopefully one of the themes that you took away from this evening is the importance of that multidisciplinary team evaluation, getting together a treatment plan, and understanding that, you know, what used to be a death wish, or not a death wish, but a death sentence to some of these patients, they can have prolonged survival. And some of the treatments that we have out there are just incredible, and we're seeing great results. And so with that, I want to turn it over to my partner, Dr. Michael Valente, to close us out.
Thanks, Scott, and thanks to all the panelists and the speakers. I know we went a few minutes over, but it was really great information, a lot of new stuff out there, a lot of cutting edge technologies, a lot of new drugs, and we're really happy that everyone could share their information. A couple of housekeeping wrap-up items for everyone. You could claim your CME. Please scan the QR code on your screen with your phone, and then follow the prompts. Tonight's activity will also qualify for American Board of Medicine, Board of Surgery, Board of Pediatrics, MOC. So details and PowerPoint handouts will also be emailed out tomorrow morning to all the members who are able to log on. And then please join us for the next Cleveland Clinic live from Cleveland Clinic broadcast. That will be June 9th from 6 p.m. to 7:15. That will be on the management of gut failure with our small bowel transplant team seen there. Once again, I'd really like to thank everyone for joining in. I know we had maybe an overzealous agenda, but I know there's so many great things that our team's doing, and I wanted to highlight as much as possible. So thank you to everyone who was able to log on. Thank you to my teammates at our metastatic colorectal team we have here. So from Cleveland Clinic, have a good night, and thanks for tuning in. Thank you.